Okay, so what we are going to talk about is spinal exercises for AS. So I've abbreviated ankylosing spondylitis or axial spondyloarthritis in here to AS. It makes my life a lot easier rather than trying to say those repeatedly. For the sake of this webinar, we are going to use axial spondyloarthritis and ankylosing spondylitis interchangeably. There are some differences between those two phrases. Ankylosing spondylitis, for example, is a type of axial spondyloarthritis. There are other types, but just for simplicity, because we're going to talk about spinal exercises, and they're pretty much going to be the same, regardless of which type of spinal problem you've got from an inflammatory point of view. So we're going to use them interchangeably for the point of this. So I just wanted to head that up front. So thank you for joining me this evening. And what we're going to talk about is we're going to talk about spinal exercise in 3 different situations. And then I'm going to posit some ideas on how we might adapt a couple of those different things with the individual as well. Obviously, we want to treat people as complete individuals. So it's very difficult. I can't really go through an individualized exercise program for the person, being that there's no person in front of us. But I'm going to do my best to try and explain how I go about approaching these 3 slightly different processes. We're going to talk about early disease, ongoing disease, and then spinal fusion. So 3 sort of fairly distinct parts of the disease process. So when we talk about early disease, so let's define early disease a little bit. And this, I would say, it lasts anywhere for individuals between a few months up to a few years. And what tends to be occurring in early disease is that there is a lot of symptom change. So symptoms wax and wane, and they get severe, or they might be a little bit better. There's also a lot of interventions. There's a lot of investigations as they go through diagnosis, and they tend to be getting either used to medications or trialing new medications. So some people, they'll go on to an anti-inflammatory, non-steroidal anti-inflammatory, or a COX-2 inhibitor anti-inflammatory, and they will do very well quite quickly. And we see that in maybe a quarter of patients do really well in that situation. Then there are other patients that don't do quite so well as that initially, and they need a bit of chopping and changing with either different anti-inflammatories or different regimes. And then some patients will go on to biologics and anti-TNF medications, even in this earlier disease process. And so there is a lot of chopping and changing at this time. So it is quite difficult to get a handle on what's going on because there is so much change. It's also obviously very new to the individual as well. So they don't really know what their symptoms are going to do one day to the next. They don't understand what's going on with the disease. They've got a lot of things being thrown at them. So there's lots of different things going on. But on the positive side, in early disease, we don't tend to see structural change. So we shouldn't have true loss of range of motion. We shouldn't be in a chronic pain state, those kind of things. There are some positives at this early stage, although sometimes they can be a bit difficult to see, especially if someone's got very severe disease, or in what commonly happens, they've waited a long time for diagnosis. So in this early disease component, what we're going to be concentrating on in the spinal conditions here is we're going to look at function. So most of the time in this early disease, we're going to be looking at maintaining function. So this is usually work and hobby related function. Typically lifting, carrying, moving, playing with children, working, can be sitting for extended periods of time if they've got a desk-based job, but it's usually maintenance of function. So typically, we're not looking at heavy lifting or anything like that with regards to trying to increase strength. We should still have retaining our original amounts of strength. We're just looking at maintenance. So our exercise programs will probably reflect that. We're going to be looking at postural, potentially interventions as well. And I put this in the early disease because there's a lot of information out there saying about maintaining posture even in the early part of the disease. So typically when you see patients with spinal fusion, they go into a kyphosis shape, so they flex forwards, particularly in the thoracic spine, with rounded shoulders and a protruded cervical spine and protruded neck. So they're very commonly early on, we're talking about maintaining posture. And again, this is about maintenance at this stage. And I really don't go too much into posture in the early part of the disease. What I tend to do is I will keep the postural exercises, in inverted commas, inside or alongside my functional work. So we'll make sure it's extension that they're going to want to be working on. So I make sure when we're looking at function, we're still retaining the ability, and this comes a bit into range of motion as well. We're retaining the ability to get full extension, full chest expansion, those kinds of movements, full flexion, but particularly the extension when we're talking about postural, so that we're making sure and trying to educate that we're not spending extended periods of time into a flexed position, which might be more comfortable, it might not be. And that isn't inherently problematic, but we're just going to keep people being mindful that at some point they need to be getting up into their fully extended position, because they are at risk of coming forwards in later disease. So I don't particularly concentrate on postural work in the early disease. I kind of slip it in the side door, if that makes sense, side door in with function. And very similar with range of motion. What I'll do with the range of motion is, unless there's a particular restriction, then we're looking at maintenance. So I typically will suggest to people, as long as they go through their full range of motion a few times in a day, that is going to be sufficient. We're not looking at increasing range of motion, so we don't necessarily need a stretching activity. We just need a mobilizing activity where they get into full range of motion. So I try to get people to think about their day. What have they done today? Have they been into full rotation? Were they required to reverse the car, for example? So they've gone full into left rotation. If you're driving a right-sided car, if anybody's watching from America and you do the other side of then you need to go the other way. But have they had both sides? Have they fully rotated? Have they fully extended at all three segments of the spine? So lumbar spine, thoracic spine, cervical spine. Have they fully gone through those range of motions? And the same with flexion. So making sure we've done that. If they haven't done that, then go through those ranges of motion, make sure they get round there and they're filling up their sort of that full amount. So again, you can, in this early disease, because there's got a lot going on, you can merge a lot of this into small programs. So you can look at what their functional requirements are, and then you can build a program around specifically like that includes some extension work and a full use of the range of motion, because you're not going for extended periods of time or extended numbers of reps, etc. So you can be quite efficient, you can be quite judicious with the exercises that you choose, so they don't have too much work to be doing alongside all those medication changes, so on and so forth. I'm really at this point as well trying to educate them as much as possible that moving their spine is not going to be detrimental to them, and in fact it's going to be extremely positive in the short, medium and longer term. The only thing I try to avoid, well, not avoid, but counsel on in early disease is loading at full range of motion. So this is an enthesitic disease. So this is going to be affecting the entheses of the spinal ligaments, sorry. And if you load them at end of range, you can cause a bit of an inflammatory reaction, which isn't problematic, but it can be uncomfortable. It can trigger symptoms a little bit extra. So we don't go into we don't load in full range of motion. I typically will do my loading exercises in the middle 50%. So cut off the end 25% as a way of trying to avoid some of that end of range loading. Having said that, if they require that for function, so if their job role requires that, then we will work into that range because they need that on an individual basis. Okay, so then we move on to ongoing disease. I didn't really know what to call this, to be honest. So it's not early disease and they haven't got spinal fusion yet. They're somewhere in the middle. This is obviously a very extended period of time for a lot of people. So if they got diagnosed onto treatment very early and they did well, then this can go from a few months out from disease onset all the way up to decades. They can go on with this process. Some patients will have no symptoms, some patients will have some patients will have a lot. There's a big spectrum of what's going to be seen here. But typically what I mean here by this ongoing disease process is they're still retaining some symptoms, but they haven't got spinal fusion. So they haven't got a physical restriction for their physical restriction, you know what I mean? If their spine isn't fused, which is restricting their range of motion, but they still have continued symptoms. And I treat these patients very similarly to the early disease process patients. The difference with these is they tend to know a lot more about their disease and what it's going to react like and how hard they can push themselves and what their symptoms are going to be like on a day-to-day basis. They tend to know a lot more of that. They also tend to be much more stable on their medication. So you don't have this pitching of symptoms quite so significantly. So you can be a bit more, typically I find you can be a bit more aggressive, you can be a bit more strong with your prescription here. You don't need to be quite so safe. So typically what we're going to be looking at here is, alongside maintenance, we're also going to look at restoration. So a lot of patients in this category, they will, in that early phase, they will lose muscle strength, muscle bulk, potentially range of motion, potentially cardiovascular fitness, function, those kind of things. So we're looking at restoring those things. So you're going to have to do that on an individual basis. Some patients will lose rotation, some patients will lose flexion, extent, you name it, hip range of motion rather than spinal. There's going to be a wide range of difference. We need to do a good full assessment, see where the limitations are, if any, and then address those specifically. And I like to do that in a meaningful way. So we look at going, okay, here is your restriction. This is what it's restricting functionally. So let's work to restore that functional ability. So if it's rotated, if they're a professional driver, the taxi driver, bus driver, whatever, and they need rotation, then we work on that rotation specifically. Quite often I'll do it in their work vehicle, so that they're seeing progress and they can see what that exercise is about. Or if they're in the gym and they can't do specific exercises because they don't have the range of motion, they can't get deep enough into a squat, for example. I've had a little bit of work on that recently. Then we'll work on those specific things. So we're looking at that restoration, but also this rebuilding of confidence, getting them to trust their abilities, their bodies, their spine, all these kind of things, that they're not going to cause themselves a big problem. They're going to be able to do these functional tasks, these functional abilities. They're going to be able to improve. And quite often, that's a lot of what you're doing is they are concerned about going into full flexion or extending or full rotation because they've had problems. The typical types of problems that I see in this category when people have had this for a long time is thoracic range of motion. So they then tend to struggle getting their arms up over their heads, but also cervical range of motion. So the neck, they lose rotation, and they typically lose extension. So working really hard on those. And then finally, we're into that third category. And these are patients where they have spinal fusion. So they may have symptoms, they may not. Again, there's a big broad range. They may have some spinal fusion, just one or two segments, or they may have complete spinal fusion. It's called bamboo spine, where the multiple segments of the spine are fused together. So this doesn't prevent them from doing exercise. And to be honest, it is important they continue to exercise. They need to maintain the bone strength in that spine, and loading that is really important. So what we start to do here is we need to be aware of the limits within which we are working. What are the bony restrictions that we are actually able to accommodate? So if you have a full bamboo spine, your spine is not going to move. And so you are not going to be able to stretch out of that. You're not going to be able to improve, even lots of soft tissue work, whatever. You're not going to be able to do that. You have to get around the functional limitations using peripheral joints, the shoulders, the hips, etc. You're not going to be able to move that spine. If you've got some segments restricted, then you can compensate a bit with other areas. But as we know, hypermobile individual hypermobile joints or in the spine can commonly become symptomatic. So you have to be careful you're then not overworking other areas. And what you'll tend to see, what I've seen in practice, let's say you've got a fused thoracic spine, you'll commonly then see they've got lumbar spine pain, because what they're doing is they're trying to compensate for that and overusing that lumbar spine. So you have to work within their limitations, and there is no substitute here for getting an opinion from the rheumatologist. How much range of motion do they currently have? How much do you think they can get back? Is it very much at all? But then that doesn't stop you from doing the movement. So I like to do with patients, you still do this sort of mindful movement. So probably you're going into rotation, you might not do it in sitting because you're a bit too restricted, but what you might do is do that in standing. You might do it in 4-point kneeling or supine or something like that. So what you're doing is you're still trying to do the mindful movements, because then you're going to get some movement at other joints, which is going to be helpful and keep sort of, I don't know if it's the right turn of phrase, but kind of mind body sort of connection where they're still going through those literal motions. Load, like I said, this is important. So I do with spinal fused patients is load their spine. So sometimes this is isometrically in a squat rack. Put load through their shoulders so that you're getting some compression on the spine. So you're loading up those bones to retain the bone density, or squats, or however you might load them. You need to get some load through that spine. I really like pulling activities to load the thoracic spine, so like a row, something like that. That also helps with the next part, which is sort of rib cage expansion, and working into the extensors. So as we talked about, if they're fused in the thoracic spine, particularly they've got very forward chin, they're going to really come forwards into a kyphotic position. So anything extension is really beneficial. So I like rows and all those kind of things, those nice things. And again, depending on the individual, I'll do that in different positions. If they've got comfort or balance issues or whatever it is, I might do that in 4-point kneeling. I might do that in sitting or standing, whatever deals with the individual most appropriately. And then rib cage expansion. This is wildly important and totally missed off in many assessments for people with fused spines. And this is obviously important to fill the bottom of the lungs with oxygen if you need to take deep breaths. Ankylosing spondylitis strongly associated with cardiovascular disease. We need to be able to get oxygen in. So there is, like as I said, you need to get some extension work in there, but nothing really solves the problem as well as really deep breaths. So if they can exercise to get well out of breath, then great. But I particularly like singing. Well, singing might be in inverted commas. It certainly would be for me. Certainly an attempt at singing. I don't know if I wouldn't go too as far as to say what I would do would be singing, but what I get them to do is usually in the car, because then there's no one else around and they don't have to feel embarrassed if necessary, if that's going to be a thing. Put their favorite song on the radio and then they belt that song out as loud as they possibly can for the duration of the song. I challenge anybody to do that. If you do that, you'll get your favorite song, 3 minutes, 3.5 minutes, 4 minutes, depending on what it is. Really belt out the lyrics, and you will be out of breath by the time you do that. And it really gets some oxygen into the bottom of the lungs. Really like that as an exercise. Use that a lot with people, and they can really get on board with it. They can do it sitting at the traffic lights or whatever they're doing in the car park of work, or whatever they're going to do. Pick their favorite tune. Taylor Swift is probably fairly common these days, but whatever situation of music gets you in. Mine's probably much more along the 80s situation. So really consider that rib cage expansion. Now, and alongside this, I just want to caution anybody watching. A lot of people go, "Whoa, we could get some movement at the costovertebral junctions with the ribs, and we could do a bit of manual therapy and move that." I really don't like people doing that. It isn't technically contraindicated, but you have potential for low bone density. You have the potential for those joints fusing. there isn't really any evidence at all that it's going to improve movement in any meaningful way in the long term. So I really think we should try and do that with breathing exercises rather than attempting manual therapy. I've seen a few patients, costochondritis, really flare up after manual therapy on the ribs, and in this population, and it's very difficult to then get back under control. So it might be tempting. I would counsel you against that. Okay, so I just want to talk a little bit about the exercises themselves and what we're doing. So these with range of motion, what we want to be looking at really in ankylosing spondylitis is the spine, sorry, just missed out a P there, spine and the hips. So working on the spine and the hips, we need to be looking at flexion and extension. And then what I see missed off very commonly is the rotation. And it's about getting that full amount of rotation a few times a day to make sure they're retaining the movement in those joints and they're not stiffening up. And keeping the spine and the hips. So again, I've been on this a few times, but can just consider the positioning. Some people will find it far better sitting. Remember, with the spinal fusion, if they're kyphosed and they're fused, they aren't going to be able to lie flat on the bed. So think about how you're going to be doing that hip range of motion. I really like 4-point kneeling. I'm not going to lie. What a position to do stuff in. Really like it. You can get a bit of load in there. You can do all sorts of fun stuff in 4-point kneeling. That's my go-to for especially when I'm first meeting people. Really like that. But make sure we're getting flexion and extension and rotation. Think about the different levels. Are you making sure that they're getting range of motion in the hips, lumbar spine, thoracic spine, and cervical spine? I see the lumbar spine done really well. I see the cervical spine done really well. And we completely miss off the thoracic spine, and people completely forget the hips, which are really commonly affected in ankylosing spondylitis. So making sure we're including those. And then the postural work. This is where I see this juxtaposition I see quite a lot of, where people are talking a lot about posture, but what they're talking a lot about is static posture and trying to adapt, what is the ideal posture maybe, or let's do this or that. I'm not so worried potentially about what posture they're in. When you see these patients, once they get into a kyphosed position, especially if they've got fusion, you're just really not going to get them out of that kyphosed position. So really what we're doing is we're aiming to prevent it from deteriorating any further, but we're also making sure that the muscles, particularly the posterior muscles, are maintaining strength, and the joints are maintaining as much range of motion as possible. So we're really looking at extension. So again, 4-point kneeling's back on the table. Love that 4-point sort of yoga camel type movement to sink into extension. That's sort of a bit more passively moving into extension. But then I really like sort of a prone position, using doing like Y movements for the shoulders to get into some spinal extension, and the rows again, really like a row to get into extension. And again, remembering lumbar, thoracic and cervical. And again, I really just see the the thoracic spine just missed so often. So people are they're doing exercises and they're compensating with their lumbar spine, and they're not getting any extension of the thoracic spine. And so I really like, as I've mentioned, a seated sort of row is a really nice way of fixing. If you can fix something into the lumbar spine, fix their lumbar spine and get into a row and really get some extension work going, that can be really quite nice. So I work quite a lot with people doing those things for their spinal range of motion as well. So that gets me to the end of the exercise sort of bit of chat. We're going to leave it open for a few minutes for any questions from you guys. If you have anything about spinal exercise for AS, but feel free to put anything in that you have questions about rheumatology in general. I'm happy to either answer those now, or I'll do some more videos at some point. Always making new content for the rheumatology parts. So any questions, pop those in. Hope you found that useful, those bit of spinal exercises for AS. I am looking at doing some recording in the gym to put some specifics into how I go about adapting some of these exercises. 4-point kneeling is definitely going to be in there, as you can probably gather, and explain for which patients and why I might adapt those specifics. So that's going to be done. I'm hoping to do that this year, but time is tight already. I don't want to scare anybody. It's, what is it, 3rd of September. My part of my family were asking me what I'm doing for Christmas, so don't scare anybody about that. But anyway, that is coming on the horizon. We'll be doing, I'm aiming to do monthly webinars like this, so keep an eye on my social media feeds as well. And any that you do miss, or if you want to catch any up, then they are on the YouTube channel. If you just type Rheumatology Physio into YouTube, I do come up at the top. I've done about 8 of these ones now that are similar, sort of along various different lines regarding rheumatology. Starting to lose count. I do have a full rheumatology course for clinicians. We talk about differential diagnosis, treatment, management. What else do we talk about? All sorts. Pathophysiology, general health, general exercise, loads of information on there. And I've recently split that up into first contact practitioner module and also a rehab module. So there's some, people were asking, I don't need the differential diagnosis bit, I just need the rehab bit. Those things are available. You can find all of that on my website, rheumatology.physio. So I'm going to leave it there. Do check out the website, Rheumatology Physio. You can find me on social media. Just type Rheumatology Physio pretty much anywhere you want. My little face comes up. You can see it on the left corner there, in the circle. Thank you all for joining me this evening. It's an absolute pleasure. Hopefully you found that useful. Any feedback, please do let me know through social media or email, and or comments on the video on YouTube. And I will see you on the next.